Good afternoon, and thank you very much for attending this session on the transformative power of shared information within healthcare systems. My name is Emma Paulino, and I will be the moderator for the last roundtable of the day. Well, speakers from the two previous roundtables have already highlighted that shared information within healthcare system not only facilitates responsible medicines use, but can actually be the driving force to change systems towards responsible medicines use.
As I said from the beginning, it's about sharing. We have multiple stakeholders, and all of these stakeholders needs to be aligned, both about the way they use the information and the way how they put in the information into system.
The single biggest mind shift is to stop thinking about personal health records and start thinking about personal health applications. It's not the record that drives usage or indeed drives any kind of meaningful use. It's when you start putting a really large set of applications, a store, if you will, of applications that relate personally to the individuals who are going to use the system, that you drive up usage in the system and that you drive up utility of the system as well.
A lot of the measure development that we deploy today is really designed to help us from a population health standpoint, not an individual care standpoint. So one of the things that gets very difficult is when we talk about measures like the Medicare quality measures, it's really designed for a payer entity or a provider entity to measure how they're doing for their population. But for a patient, it doesn't really tell them much about individual outcomes. If you don't have access to the information, you can't even do the measurement. So I think one of the fundamental concerns here is in the developing markets, how do you create the information resources necessary to measure how you're doing? The other area where I think there's also room for improvement is around patient-reported outcomes. Because I think the one thing we haven't really touched on is how pharmacy affects not only measurable health costs and health outcomes, but individual quality of life measures and functional status, as well as obviously the sort of direct economic benefits of that in terms of having a population that's able to work and able to participate more fully in society.
On any given day, 100,000 patients in Kaiser Permanente receive pharmacist-led anticoagulation care. We've been able to show through our research that we've been able to decrease the incidence of anticoagulation-related adverse events by 40%.
My expectation is once the data is available, then people will start to actually pick up those apps. This is the most connected generation there's ever been. We're all playing with our iPads and downloading the latest app on where the restaurant is or whatever. We will do the same thing with our health data. All we've got to do is have a few teasers, things that get us interested, that connect us to our daily lives.
Finally, on interoperability, I think ultimately the ultimate agent of interoperability is going to be the citizen. Mm-hmm. They are the people who fundamentally should and will or already do own their health information, and they will become the conduit of being able to bring that information between different systems and have it interpreted in different ways.
What patients want is not to know what they did, but what to do in the future. And I think that the system has to keep in mind that the ultimate goal here is to take all of that information that we're generating in these systems and allow patients to have a much more effective dialogue in what is, by definition, a mediated environment where professionals make the final care decisions.
When we do the cost-benefit analysis in a population that is highly, highly dispersed, you can actually see the benefit, and we can already see this for 40,000 Aboriginal and Torres Strait Islander people who live in the very remotest parts of our country. So we already have a shared electronic health record for those people. We can already demonstrate the benefit in an Aboriginal person who will walk into a remote clinic in the northern part of South Australia. That person's record is then available. We don't get polypharmacy, we don't get a change in diagnosis, and we actually get much better adherence. So we can start to demonstrate, particularly in those populations, the actual benefit for us in those populations.
An awful lot of our countries, for example Ireland, we've disparate electronic patient record systems. We don't have a national record. Patients don't have the ability to carry their information with them. We have huge information gaps in information between primary and secondary care. So I think the first purpose of any health informatics solution should fill in those gaps where possible and give the patient the power to have their information with them when they need it, when they want to share it with their physician or their pharmacist or their practice nurse, whatever. I think that should be the first purpose. What we need to realise is patients are actually assuming already that we are sharing information with each other. It's been proven, I think, in studies in Holland and in Ireland and in Scotland. And we're not actually sharing that information. So we have the evidence to say that patients expect us to do this, so we need to get moving on it. And they are assuming that we are operating with all the knowledge that they think we have. We're not.
So the National Prescribing Service is really one of the pillars of our approach to the use of pharmaceuticals, making sure that prescribers and users of medicines actually have access to unambiguous information about the way those medicines should be used, the circumstances, etc., etc.
Interoperability is the future. It will be because of grace to interoperability that you will be able to have a continuum care of the patients all around the world, a seamless care for all the patients. It should be there only for hospital, community, all health professionals should be involved.
There's a significant policy implication around not only patient privacy, but what expectation there is for healthcare providers around privacy and information sharing. And secondly, around data use and data ownership.
There are some dozen American pharmacy organizations working together with a number of corporations to try to crack the nut of pharmacists not being included in the process. There are many electronic health record initiatives out there. Most of them leave the pharmacist out of it.
So providing quality medical information through mobile applications could be one of the area which needs to be further seen on, which is because this information is very portable, economical. We have done this in India with National Formulary of India. And this formulary is the first formulary which is available free on mobile. And it has been downloaded in 50 countries, in the developing countries mainly. So there is a need for this kind of information.
But it is about a dialogue between patients, professionals, civil society, and the private sector who will basically innovate, roll out applications. And you really do have to have a very good grasp of how people seek and then receive healthcare.
Thank you very much for your last messages. Well, I can say that we can conclude that robust systems of data collection and analysis are indispensable capabilities for any health system attempting to increase the responsible use of medicines, prioritize interventions, and effectively allocating resources. I would like to thank once again our speakers and contributors for today, and I would like to ask for you a round of applause for everybody.